The first technique of monopolar endoscopic enucleation of the prostate was introduced in 1986 by Yasunori Hiraoka, but only in 1998 the method of Holmium laser enucleation combined with mechanical marcellation was described by Peter Gilling and Mark van Dover. With 20 years of research into the technique, HoLEP surely is one of the most studied options of transurethral prostate surgery. Moreover, Holmium laser still remains one of the most efficient energy sources for enucleation of the prostate. We have performed more than 1500 endoscopic enucleation of prostate since 2013. Amongst them were monopolar electroenucleation of the prostate, Holmium, and thulium laser enucleation techniques. Current surgery was performed with Holmium laser with maximum power of 100 watt. Multiple approaches to HoLEP were used en bloc, 2 and 3 log techniques. All of them rely upon identification of the surgical capsule and retrograde enucleation along this plane. We employ the 2-lobe technique with a single bladder neck incision in either the 5 o'clock or 7 o'clock position. We prolong the incision to the level of Burr-Montana. Incisions and least level are performed at 40 watts, while other operation steps are performed at 70 watts. We think this precaution may help to prevent postoperative incontinence. Still, many surgeons believe this may be unnecessary. During enucleation of the left lobe, we move the resectoscope counterclockwise, combining laser energy and mechanical movements. You may see that enucleation goes well, and extensive amount of it is only performed with laser energy in contrast to thulium and monopolar enucleation. The main property of the Holmium laser is that it has no direct influence on prostate tissues. Initially, the laser beam only affects the liquid close to the optical fiber. At its tip, each laser pulse creates a bubble of vaporized water. The diameter of the bubble does not exceed several millimeters and depends on laser energy. The bubble usually only exists for the duration of a laser pulse, about 500 microseconds. When the Holmium laser makes incisions, first the vapor bubbles tear the tissues, and only then the tissues are affected by laser energy. Note that when using Holmium enucleation, the surgical site appears as white fibrous cords due to the effect of high temperatures of the vapor. The next step is the 12 o'clock incision, which is extended from the bladder neck to the seminal colliculus. Like the incision at 5 o'clock, it must be deep as to reach the circle fibers of the surgical capsule. The incision is connected with the previously made one, which leads to enucleation of the lobe into the bladder. Still, some surgeons will enucleate a lateral lobe and continuously cross the anterior connection to the other side, performing en bloc enucleation. The right lobe of the gland is enucleated in a similar manner. The initial incision at 7 o'clock is made clockwise. The 11 o'clock incision is then extended along the capsule to join the previously made one, thus exposing the right lobe. The property of the Holmium laser allows using the no-touch technique, which means there is no actual physical impact on prostate tissues. The effect of laser on tissues is instant, which is why Holmium laser is characterized by good hemostasis. The vaporizing effect of Holmium laser energy is minimal compared to other lasers. The last step of the operation is marcellation of the adenoma. In the absence of a marcellator, it is possible to use the mushroom technique for removal of the tissue. However, it is a very time-consuming process. Conclusions. Nowadays, Holmium laser enucleation of the prostate is a widely recognized technique of the non-contact enucleation of the prostate. In 85% of our patients, the catheter was removed within 24 hours. The rate of postoperative incontinence 6 months after surgery did not exceed 2%. With an anatomical approach to the enucleation, the relapse rate was no more than 3%.